Okay, so we're going to go ahead for week 4. We're going to talk about chapter 21, and then we're going to do a quick Kahoot. So I should get you out of here on time. Thanks everyone for coming back. I know it's a lot to ask for you guys to take your exam and then come back, but we do have another hour of class. Just so you know, there's classes. This 204 class is taught throughout the week. So me and the other teachers are not going to have a chance to meet until Saturday because there's a class on Friday. So I can't give any preliminary scores. I can't post any scores. We're going to meet 2 p.m. on Saturday. So kind of look for your exam scores around 3 p.m. on Saturday. They should be in Canvas. So we're going to go over the exam and see if we have to throw out any questions or give any point backs, etc. So if anyone has any questions about that, please let me know. Otherwise, we'll go ahead and get started. Hopefully you guys can see my screen. Let me make sure that got my screen sharing on like I'm supposed to. Okay. I'm gonna go ahead.
I got one question.
Sure.
Can you let us know the overall class grade?
No, unfortunately I can't. There's been some they monitor me also. So it's from the top up that we're not allowed to really give out any information until we have a chance to meet as a class, as a group of professors. So I apologize, Robbie. I'm not allowed to do that. Okay, any other questions? Oh, I didn't quite hear that. Could you say that again?
Robbie, you mute. Okay.
Okay. Alrighty. If you have a question, you can also pop it in the chat and I'll take a look at it. I just checked. Looks like my screen share is on. So we're going to go ahead and start talking about chapter 21. Might go through, and if you guys are not asking a question, please make sure you're muted.
That's not me.
Okay. So chapter 21, the child's experience with hospitalization. So, when we talk about pediatrics, we're always talking about whatever the developmental level of the child is. So always thinking about their developmental level when you're developing your nursing care plan, and then also thinking about what type of setting they're in. So acute care hospital, this is your general hospital that you always think about, multiple inpatient beds, emergency room, etc. An extended care or long-term care facility, this is more common in adults, but they do have them in pediatrics. For example, a patient that has a tracheostomy that's on a ventilator, a lot of times they'll go to like an extended care facility till they get all the education and training and they find a home care team that can do vent care at home. So kids can end up in these long-term care facilities. An urgent care center, your doctor's office, there's some research centers, outpatient centers, and then there are children that get home care. So kids can get care in all of these different places. They have to think about what environment they're in and then what their developmental level is. We always talk about, we kind of break it down: infants, toddlers, and preschoolers, school age, and then adolescents. These are the basic age groups we're talking about when we're thinking about their developmental level and how you would adjust their plan of care. So separation anxiety, it can occur just in life. It's common. It's a common thing that happens around 6 months of age. But toddlers are really the ones that, really express their anxiety the most. And we definitely see this with kids are in the hospital. So if you have a toddler that has to come in and spend several days in the hospital and then their parents have to leave to go to work, that can be really traumatic for that toddler. So these are the 3 basic stages: the protest, despair, or denial. So the protest is the initial stage. The toddler is losing his mind, screaming because his mom and dad are gone. The despair stage, the toddler doesn't really want to interact, isn't really playful. And then the denial detachment stage, the toddler starts to play with toys, etc., trying to kind of have like a stiff upper lip and get over their separation anxiety. And then when the parents come in, they don't want to interact with their parents. And that can be really hard for their parents. And so as a nurse, you really kind of prepare parents that this is like a normal process that kids go to. Oh, see who's not muted. Okay, so I can't find who's not muted, so I think it stopped. Please make sure you're muted if you're not asking a question.
Somebody's logged in on 2 devices near each other. That's why.
Okay, let's see here. Okay, so if you're logged on 2 devices, could you log off of your cell phone now?
Get them out of here.
Oh my gosh.
Yo, what is it? It's a phone, and you must be on the phone in the.
Whoever the Emmanuel person, that's who that is, Professor Rebecca. Whoever
Excuse me?
Emmanuel,
Okay. Thank you. Let's see here. Sahir isn't muted. Let's take a look.
yeah, it was Sahir, but now they're muted now.
Okay, thank you. So going back to these stages of separation anxiety. So as a nurse, you do a lot of anticipatory guidance and kind of preparing parents that this could happen, that their child can go through these stages, and you should still encourage the parents to be there as much as possible. So sometimes parents, they'll see that their kid is not interacting with them when they come in, and they think, oh, well, they're fine, they're better when I'm not here. But you always want the parents to be there as much as possible. So if you're ever kind of given a choice on how to help children with separation anxiety when they're in the hospital, the answer is to encourage their parents to be there. So obviously the child's reaction to hospitalization is going to depend a lot on their age, but it also depends on, if they've been in the hospital before, if they have any experience with hospitalizations, sort of family network they have, their overall emotional health, and if they have a good home life. And there's very specific things that are stressful for kids when they're in the hospital, being separated from their parents and their friends, pain, and then fear of body intrusion. There's very specific things that happen to kids in the hospital that are legitimately fear-provoking. So, as a nurse, you need to be prepared for the fact that when the child has fear that violates their trust. So then you're going to have to work extra hard to have a relationship where the child trusts you because of the fear that they have related to the hospitalization. So it's a balancing act. You might have to restrict their activity. They can't always go to the playroom, et cetera, if they want to, because they could have an infectious disease. So you need to make sure the child and the rest of the children around them are safe. But then also recognize that just kind of the process of being in the hospital can really create fear for them, and it can also kind of make them not trust the hospital staff. So something that commonly happens, this is also common among toddlers, is they'll have like a regression of behavior. So maybe you'll have like a 2.5-year-old that always drinks from a cup, but then when he comes in the hospital, he only wants his bottle. So this is normal for kids to regress to previous behavior when they're stressed and in the hospital. So once they're out of the hospital and they're back to their home routine, their behavior should go back to normal. But this is another thing that you might need to prepare parents for, that, a kid that was potty trained, needs diapers, or a kid that drank from a cup wants to drink from the bottle. They have these sort of regressions of behavior, and then it's a response to their stress. So, there are things that happen in the hospital. Illnesses can cause pain. Procedures can be painful. So sometimes kids will not tell you they're in pain because they're afraid that means you're going to give them a medication or a shot. So always be on the lookout, remembering that pain is really the 5th vital sign, and that if you're controlling your patient's pain, they're going to have a better hospitalization. And then remembering the different pain scales. So like the infants really is going to be a behavioral scale where you're observing them. And you can't really do any sort of like a scale where they have to talk to you until they're at least like 4 or 5. So infants and toddlers are really going to be behavioral scales. And then you can do asking them more questions, like a preschool, school age. You can do like the FACES scale. Once they're like 8, 9, then you can do the 1 to 10 scale where you ask them. In addition to giving them pain medication, there's several things you can do as a nurse to help relieve their pain. You know, if they're old enough, you can have them draw, have them express their feelings through drawing, basic distraction, offering video games, you know, relaxation, things like that. All of this can help manage the pain. And then a baby, think they always really like a pacifier. So making sure they have a pacifier to suck on can also help manage their pain. And we talked about this when we were going over the information for exam 1, that kids really, they're higher risk for toxicity because of their immature kidneys and liver. So you need to make sure that you're being extra careful to make sure all of their doses are based on weight, and recognizing that they could have impaired clearance that made them increase risk for toxicity. So if kids have good pain control, then they're more able to focus on their surroundings and interact with their parents and their family. And then if they don't have adequate pain control, then they can really fixate on the pain, and it makes it generally harder to manage their care. So, you know, if at all possible, you want to be giving medication around the clock, so the pain never gets out of control. So if, you know, you can give Tylenol every 4 hours, you give the Tylenol every 4 hours so the pain never reaches like a 7, 8, and they always have pretty good pain control. So there are 2 medications we give frequently in pediatrics for pain. One is Tylenol, and the other one is ibuprofen. And I would remember the basic dose for both of them. So Tylenol is 15 milligrams per kilo every 4 to 6 hours. And then Motrin is 10 milligrams per kilo every 6 to 8. So if you're ever working in a hospital, you're going to be giving both Tylenol and Motrin for fever and pain, and they're given pretty close to around the clock for a lot of kids to kind of keep their pain under control. And you always want to be checking the dose to make sure it's right for their weight.
Professor, what did you say about Tylenol? It's given how many hours? 4 to 6
can-
hours?
Every 4 to 6, and the dose is 15 milligrams per kilogram.
Thank you.
You're welcome. So a very specific sort of procedure that happens in hospital is something called conscious sedation. So conscious sedation is giving intravenous drugs so that the patient has impaired consciousness but is still breathing on their own. So you would do this maybe for a central line placement or for a chest tube placement, maybe for a lumbar puncture. So patients that get conscious sedation, they're going to have a nurse. So they're going to be in a 1-to-1 nurse to patient ratio. And they're going to have to be on a monitor that monitors their vital signs and their oxygen level. And usually you have to be trained in conscious sedation to be the conscious sedation nurse. And they're monitored 1-to-1 until they're back to their baseline before the sedation. So I love hearing people's experiences with language interpreters. So does anyone currently work? What sort of language interpreters do you guys have access to right now in your current jobs? Do you have a language line, or do you
They're
do you have
supposed to use the
interpreters?
language line, but I see a lot of the doctors and nurses use just like staff on the floor, like PCTs and stuff.
Okay, so that's what we really want to try to get away from. I'm glad you said that. So the language line, you know, hospitals are required to have it. So there should be like a phone that you can pick up, and you could call for a specific language interpreter. So you always, you know, you want to use a professional interpreter. You should definitely not use family members. You know, a wife might not translate everything for her husband, or they might change what you're saying. And also there's like privacy issues. So you should never use family members. And then you're going to do a lot better at, you know, giving care if you're using a professional translator, and it is regulated by federal law. So I don't really think anyone is going around making sure that you're not grabbing the radiology technician to translate for you, but it really is the best care. And so you should always be using a professional translator. In addition to the interpreters, just always thinking about cultural sensitivity. You know, you can't be knowledgeable about every culture out there, but a lot of times there'll be a specific culture that you might have experience with. It could be, you know, Vietnamese or Russian or whatever. So knowing what you're more likely to have contact with, and recognizing that they could have different responses to nonverbal cues and body language than the culture that you're most familiar with. So these are all things that go into how different cultures how they respond to healthcare personnel. So, personal space, smiling too much or not smiling enough. If you maintain eye contact, if you touch, if you seem like you're focused on them. So, for example, a Russian person might think that someone who's smiling too much is not being truthful. Whereas a Latin American person might think that if you're being really stern, that you're don't like them. So, different cultures will respond differently to these different non-behavioral cue or nonverbal cues. So just kind of paying attention to that and trying to think about the different cultures that you'll be working with. So I think we've talked about before, whenever you're working in pediatrics, you're not just dealing with the patient, you're also dealing with the entire family and the parents. So as a nurse, you really do need to be available to emotionally support the parents. They can be angry or stressed or crying. And part of your job as a pediatric nurse is to be there for the parents. And if there isn't good communication, and the nurse is going to be the person who has the most contact with the family, if there isn't going to be good communication, that can lead to fear and anxiety in both the child and the parents. So if at all possible, things can get stressful at work, but really you should try to be very calm and matter of fact. When you're dealing with somebody that isn't like a child, that doesn't really have the cognitive skills of an adult, you don't need to go into great detail because that can just cause more anxiety, but you do need to give them very simple explanations so they can understand about what's happening. So this is all things that I think we've gone over, that things to think about is you're dealing with, the whole family unit. So we call it family-centered care. So you want to have as liberal visiting hours as possible. The hospital where I worked, parents were always allowed in. There weren't any visiting hours for parents. They were always allowed in. If you can have consistent caregivers, if a kid's going to be there for 4 or 5 days, that every day they come in, they have a nurse that they know. Try to maintain the daily schedules from home as much as possible so the kid doesn't have a disruption in his routine. And just recognize that this can be really hard on the parents. So depending on the age of the kid, they can be they're able to participate in decisions, and that's important if they're old enough to understand what's going on, that you give them that opportunity, because that'll make it less frustrating and less scary for them. So adolescents in particular can really do a lot of medical planning and learning the skills to manage their own illness. So, in the ideal world, every pediatric patient would have a private room, but that's just not possible. So you're going to have to be thinking about roommate selection. A 5-year-old is probably going to do less well with a roommate than a 15-year-old. So adolescents are generally, if you have adolescents that you can put together, that's great. Think about the cognition. You don't want to put someone who's having a mental breakdown with someone that's not. And also think about like disease transmission. You don't want to put someone who's immune compromised with someone that has an infection. And then also think about just the placement. Adolescents, a lot of times they don't like to be in the front of the unit, because then a lot of people walk by their room and they feel like their privacy is being violated. So if you put them in the back, that's better. It's also important to remember that some adolescents are emancipated minors and they're able to make their own medical decisions. So if they're an emancipated minor, then they do sign their own informed consent, even for things like surgery, et cetera. This means their parent is not their guardian. And then also you do need to be familiar with the state laws with regard to adolescent patients. And this particularly is probably going to be related to things like birth control, having access to be screened for sexually transmitted infections. Some states, children as young as 14 can get birth control without their parents' permission, and sometimes it's 18. So you need to know where your state, what your state requires for you as a nurse. And I think you've talked about this probably in other classes, that really discharge planning begins on admission. So kid comes in, he's at home, he's on tube feedings and he's not gaining weight, and you change the formula and you change the feeding schedule when he's in the hospital. Well, as a nurse, you need to make sure that he has the home care equipment, the new formula, the plan for the weight checks following the hospitalization, all of that needs to be set up when he comes in, and you really need to start thinking about that right on admission so that when he goes home, all of those pieces are in place. For the more complicated ones, you're probably going to have a case manager that's helping you, but it's still ultimately the nurse's responsibility who's doing the discharge to make sure that everything is in place when the patient goes home. So, this is part of the anticipatory guidance that you give to parents, kind of make them know that kids can have separation anxiety. They might be clingy, could have regressive behavior. You want to be firm and consistent and also kind. It's really kind of a balancing act. And for the kid, you want to be truthful, but you also want them to be able to be a kid and to allow time for play and to do things that are not just focused on their illness. So if you discharge somebody from the hospital, you need to make sure that you're really doing a good job of documentation, who took the child home, what time, the child's condition at discharge, how they went home, what medications they were on, and the instructions to the caregiver. And the caregiver has to sign the discharge instructions, acknowledging that they understood the information. And it's not unusual for kids that have chronic illnesses that they actually have home care. So home care nurse that comes to their house. There's also hospice care, and there's caregivers that provide respite care so that the parent or the primary caregiver can get a break. Does anyone have any questions about any of this information? Okay, so I'm going to go ahead. There's a quick Kahoot to kind of reinforce this information. And then after we finish the Kahoot, you guys will be free to go. Let me pull it up here just a second.
Professor, we can't hear you.
Do you guys hear the music in the background to start the Kahoot?
No, ma'am. We just can see it.
That's weird because I'm not on mute. Are you able to hear me when I'm speaking to you now?
Yes, ma'am.
Okay. I'm not sure. Go ahead and log in, and then as long as you can hear me, I think it should be okay when we do the Kahoot.
Okay.
Okay, we'll go ahead and get started here. Make sure here. So first question, the mother of a child with CP redoes many of the things as a nurse does. How should the nurse respond? Please share with me some special things that you do for your child. Why don't you go have a cup of coffee? You must be exhausted. Would you like to do all of your child's care, or stop criticizing me? I'm doing the best job that I can. All right. So good job. Most of you that answered got that one right. So yeah, so kids that have CP, they do need a lot of care, but usually the parent knows them really well. So you want to involve the mom in the care, but as the nurse, you still need to be the one that's doing the care in the hospital. So just talking to the mom and seeing if you can figure out what she does at home. So what is the best pulse location for the nurse to use when assessing the heart rate of a 12-month-old infant? The radial, the brachial, the apical, or the femoral?
Typical.
All right, so good job. So these other ones, this is trying to get you to remember that when you are assessing an infant, that you really need to listen with your stethoscope to get their heart rate. So these are the ones: radial, brachial, femoral. These are all filling. Apical is where you put the stethoscope to listen. So good job. So the nurse is giving medication to a 2-month-old and there's no ID bracelet. What should the nurse do? Give the medication after confirming the child's name with the room number, delay the medication until the admission office makes a new bracelet, confirm the identity with the charge nurse, make a new ID, and then give the medicine, or ask the charge nurse to give the medication. Yeah.
Delay.
So the admission office doesn't need to make the ID. You can make these right in the unit. You do need to confirm the identity before you give the medication. So you should confirm the identity and then make them a bracelet and give them it. What strategy might the nurse use when administering oral medications to a young child who's reluctant? Tell the child the medication is candy. Mix the medication with chocolate milk. Give the medication quickly while the child is crying, or offer juice to the child when the medication's been given, after the medication's been given.
Offer juice. Yeah.
Yeah, so you do want to offer juice. So good job. I just want to point out, I'm glad that you're participating, but please don't shout out the answers so that everyone has a chance to try to answer the question. So you don't want to tell them it's candy, because that's a lie. You don't want to mix it with the chocolate milk, because then you don't know how much medication they got. You don't want to, torture them by give it to them when they're crying. So yeah, offer them a little bit and then let them take their favorite, a sip of their favorite juice when they're done. So how often should the PIV of a child who has continuous infusion be assessed? Every 2 hours, hourly, every 4 hours, every 3 hours. Okay. Yes, so it is hourly. So we talked about this last week. If you ever have somebody that's on a continuous infusion, you need to make sure that you're checking that IV hourly. So a 4-year-old asks cheerfully if an IM injection will hurt. What is the nurse's most effective response? Yes, your mom and I are going to hold you down so you will be still. No, would you like to see the syringe? Yes, it will sting a little, or no, it'll be over before you know it. Right. So to be honest with them, yes, it will sting a little bit. You don't want to lie. You don't want to tell them, you don't want to scare them, tell them you're going to hold them down. So good job. So a infant's dry diaper weighs 2.5 grams and the wet diaper weighs 47 grams. How would the nurse record the urine output? 47.3 milliliters, 40.5, 44.5, or 47? Right. So this is just going to be subtracting the dry weight from the wet weight, and then making sure that you remember that 1 gram is equal to 1 milliliter. So if you subtract the 22.5 from 47, you get the 44.5. So the nurse cares for a child that weighs 15 kilograms. What is the maximum dose of Tylenol that the nurse anticipates being ordered? 100 milligrams, 150 milligrams, 225 milligrams, or 250 milligrams? Right. So this is just remembering that the Tylenol dose, the maximum dose is going to be 15 milligrams per kilogram. So 15 times 15, you get the 225. So the nurse needs to start an IV on an infant. What intervention is most appropriate for the nurse to implement? Provide a simple explanation for the child, suggest coping techniques, let the child examine the equipment, or involve the parents. So very good. This is trying to get you to think about this is an infant. So, you really need to get the parents involved. Child can't understand explanations. They're too young. Coping techniques aren't appropriate for their age, and they don't need to examine the equipment. They don't know what's going on. Alrighty. The nurse is preparing to obtain a throat culture on a toddler patient. What intervention is appropriate? Explain the procedure in detail, model the desired behavior, encourage the child to ask questions, or instruct the patient not to yell. So very good. So, a toddler, really open your mouth wide, show them what you want them to do, and they'll kind of copy you back. They're too young to really explain the procedure in detail. You don't necessarily want them to ask a bunch of questions. Also, their toddler might not have those language skills. They probably are going to yell a little bit when you stick that cotton thing down their throat. So this is definitely the best answer, to model the desired behavior. All right. Podium. Very good. Let me see. All right. So good job, you guys. When we're done with class here, I'll post the lecture and the Kahoot link in the announcement section for you guys to practice. And does anyone have any questions, anything that you're concerned about before I let you go?
I had a question about one of the questions that was on the exam, but I was gonna ask you once everybody left.
Okay, go ahead and stay on when people leave and I'll talk to you.
Okay.
Okay, does anyone else have any questions?